Laser pointer up. Good morning, everyone. It's a real pleasure to be here and speaking with you today. Both Nish and I will be going over gene therapy basics, but also some specifics on what we're doing with GDNF gene therapy. We're really excited about. These are our disclosures. We're both employees of the Ask Bio, and please let me know if you have any questions about this. Today, just to give you a kind of rundown of what I'd like to walk through today. So I think there's a lot of ideas about what gene therapy is. I think there's a lot of maybe misunderstanding of what gene therapy is and what it isn't. So I want to make sure we can kind of dispel some of this. I want to talk about what it is and what it means to do gene therapy in the brain, and why would we even think about gene therapy for something like Parkinson's disease. I'm going to then hand it over to Nisha, who will be able to give you an update on where we are with GDNF gene therapy. We have some interesting data that just was reported, and then just some basics on how to participate in clinical trials and a little bit on who we are as AskBio. So I don't need to tell anyone here in the room, Parkinson's is very common. I think some big takeaways and a lot of what we've heard recently in the past year or so is that there's clearly an increase in how much Parkinson's there is in the world. This is why you're going to be hearing from Boss Bloom about why this is such a pandemic. There's something here. There's just a lot of Parkinson's. Interestingly, I think we've always known there's maybe a slight predominance for men. But again, at the end of the day, this is affecting a large number of people. And this is part of why we're so interested in looking for a new way of treating Parkinson's. As many of you probably have experienced, the treatments that we have, they work, fairly well for a certain amount of time. They don't cover all of the symptoms that bother most of our patients, and they don't work great over longer periods of time. And this has really, been a challenge, not only for making better drugs, but also just for patients that are living with these symptoms and watching the symptoms of Parkinson's just get worse over time. Again, there's medicines work. We have, medicines that do improve mostly the motor symptoms of Parkinson's disease. And it's really the challenge that a lot of patients face with, the day-to-day variation, the unpredictability of the symptoms, and really the fluctuations of the day-to-day that really become a big problem. We are pretty good at treating the motor symptoms. I think there's a lot of interest in trying to do better with the non-motor symptoms. But at the end of the day, some patients are really looking at taking something like a surgical approach to manage their Parkinson's symptoms. And this is one reason why DBS has had such an important place in the management of Parkinson's. However, everything that I've just mentioned, nothing is actually getting at the root cause of the Parkinson's disease underlying pathology. And nothing has actually been able to alter the disease course or really have an effect on disease modification. And this is really what has opened up the field for Parkinson's to be looked at for something like gene therapy or cell therapy. Again, these really novel disease modifying type of therapies, excuse me. So you heard mentioned already, we've had decades of gene therapy for Parkinson's disease already. So why is it still taking so long? Why don't we actually see something approved today? And I'm going to tell you it's because there's a lot of challenges with trying to do gene therapy in the brain. So one of the first questions is where do we go in the brain? Do we directly, get something into the brain? And if so, then what part of the brain should we be going to? Another challenge I think more recently has been acknowledged is, is there a right type of Parkinson's patient that we should be considering for gene therapy? And is there a right time in that disease process that we should be intervening? And should we be thinking about that depending on what kind of gene therapy or cell therapy we're going to be doing? Another main challenge that Dr. Chabria and I are going to be facing here is how do we prove to ourselves, to the FDA, to other neurologists, the patients, their families, everybody, how do we really demonstrate that we have actually modified the progress of Parkinson's? When this disease moves so slowly over so many years, how can we really show that we've really made a difference and how somebody looks, 2 years, 5 years, 10 years from now? So this is just really some of the main ones. Many other challenges exist, but these are some of the key challenges we are facing. So gene therapy, novel regenerative type of medicine. This is a totally different way of approaching, most diseases. We don't really have great treatment options for something like Parkinson's if we're thinking about something to actually get at the underlying cause of the neurodegeneration, the thing that's causing the cell death in Parkinson's. Now, with gene therapy, because of the way that it works, and we'll get into that here in a minute, it lasts for a very long time, and we should be able to make this work with just a one-time administration. It's a novel, really unique feature of something like gene therapy. And again, the whole reason to think about something like this, the power here is that we're hoping that there is potential for neurorestoration, really a regenerative process here to help and really change the course of Parkinson's disease. Okay, so let's get down to some of the nitty-gritty here. So what is gene therapy? This was a question my mom posed to me once, and so I found it was very hard to describe this. So I'm going to first start with what gene therapy is not. So we are not doing gene editing. So this is not like CRISPR. I think that is, a lot of people may know about this term in the news. This is not what we're talking about. That's totally different technology. This is also not cloning or not making Dolly the sheep, although I think people sometimes do think about this sometimes when we talk about genes and gene therapy. This is also not how you make designer babies. As high sci-fi as that may be, this is not also what we are doing. And to be clear, this is also not cell therapy. So that's a whole other technology that happy to answer questions about, but also not what we're talking about today. But rather we're talking about gene therapy, and gene therapy means that we're using genes as our medicine. And in this case, we need to kind of start at the very beginning. So what are genes? So genes are the pieces of DNA that carry the genetic information that gives us the blueprint for everything from our nails to hair color to how tall we are. And there's recently we've had a Human Genome Project has read out, and you can see how many genes that we have. And in fact, only about 1% of those genes are what make us all different and different looking from each other. And it's really just the small changes that make all these features different. If you follow this figure down below, all of our cells, all of our body's made up of a whole bunch of our cells. Our cells all have these chromosomes. I'm sure you've seen like these X's before. Those chromosomes are then all made up of DNA, and our DNA is made up of a whole bunch of genes. What our bodies do when they have these genes that need to be read, the body then reads them and basically turns them into a protein, and the protein is really what does the business end. It's what makes the eyes blue or brown. The proteins are really what do the work. Okay, so follow along with me. So again, DNA are our genes and genes are our DNA. Okay, so let's go back to the classroom. So bear with me for a few minutes here. So again, think of genes as like our instruction manual, a blueprint, and it guides everything from the survival and just overall health of our cells. And again, so when cells and all of our cells every day, our cells are reading our genes for the instructions and things that are needed to again help keep the cell alive and healthy. And therefore, new proteins are being made all day long. And this is, again, normal functioning. What we do with gene therapy is we take advantage of that already existing property. So again, reading the DNA, making a protein, and we do this with gene therapy to then read the DNA of our gene of interest and make the protein that we think is going to be helpful in that particular situation. And this is how we use genes to help make the medication. They basically serve as our medication. So in our case, what we're going to be hearing about a lot today is AAV2 GDNF gene therapy. There's a lot of letters and numbers here, but basically we're using a package here. In our case, we're using AAV2, and inside this is our transgene. This is our little piece of DNA. That is what we're using to say, hey, we want you to make more GDNF. Now, this has been used for many years, and part of the reason we're using that packaging in particular, that AAV2, it's because it's really good at getting into brain cells specifically. We've looked for many years. This is one of the other challenges. What's the right packaging envelope in order to be able to get it into the right brain area? And we think we found the right one for this particular condition. We also have seen both in preclinical work with animals, but also in early studies with the same AAV2 GDNF, that when it's there for a long time. It's able to continue to make that GDNF for years and years. And we can talk about that a little more coming up. But I think more importantly, and what a lot of people are going to be wanting to know today is it safe? And this is the other big benefit, is because there's been so many years, decades of experience with this AAV2. We have had now hundreds of people with this in their brains. That gives us a sense of safety. It's reassuring. And there's other benefits that we can get into later too, but it's not just where we're putting the gene therapy, but it's because the way the brain works, we're actually able to get benefit all throughout the dopaminergic circuitry that's affected by Parkinson's disease. Okay, So this is just another way. I'm going to go take a couple of ways of trying to explain how we do gene therapy. So bear with me. This is an analogy that's worked really well for many people. So think of our gene, so our little piece of DNA that we're putting in. Think of it like a letter. So it's a message you're trying to send to a cell. And we think of our AAV2. So this is our AAV. Think of it like an envelope. And just like you want to get a letter sent to somebody, you have to put the letter into the envelope and get it mailed. And so this is exactly what we do. Basically, in a test tube, we're able to put these things together. The DNA goes into our envelope. We get it packaged, and then we got to get it delivered and addressed correctly. And that's how all these little spikes on the outside, this is part of how we get it to go right into those brain cells that we're interested in. And then for our delivery truck, actually, we're using brain surgery. And then how this works is that just like in every other condition, with when we're using something like a virus, it's really good at getting the DNA into the cells that we want it to go into. And in this case, we want it to go right into the very particular brain cells. And then we want those brain cells to take that message, get the envelope out, throw it away, and read the message. And this is exactly what we end up seeing. And this is where then we say, hey, we want you to make more GDNF. And that's precisely what happens. And these little proteins out here are the GDNF that's being made. So nice little cartoon here again. So this would be our little gene of GDNF. And this is our capsid. So this is the AAV. And we need to now package them together. Again, they just being brought together basically in a test tube. And they like to package. And then we need to be able to get the gene therapy right to those brain cells. And that's the next part I'll show you. Once it's there, it does exactly as it does in nature. And all that's left behind now is just that little gene that we want. And the cell does what it does every day. It reads that gene that we want it to read. And in this case, it's making all these little green dots. That's the GDNF that we're asking these cells to make. And one other big benefit with GDNF is that it's made and then it's secreted. And so all the cells around it also get to see the benefit of GDNF. And this is a really important part of why we think we've seen so much benefit. So as I've already said, we have medications for Parkinson's, but there's only so much benefit over so long and not for everybody. And I think, it's important to consider that gene therapy isn't just for genetic diseases. However, we do know there's a lot of genetic causes of Parkinson's. That's not what we're looking for here. It's really idiopathic PD that we're looking for. But there's still potential benefit for something like GDNF, really trying to get at the root cause of Parkinson's. And again, this ability to address symptoms in the underlying disease and not just the symptoms, this is really the potential benefit of something like a gene therapy. And another big potential upside is this looks to be a one-time therapy. So as it was mentioned, GDNF specifically has been looked at for Parkinson's for many years. This was first discovered in the early 1990s as necessary to develop the dopamine cells as an embryo. So in infancy, you have to have GDNF just to even develop those dopamine neurons in the brain. And then we also realized that GDNF is still needed by those dopamine cells even as we get older. And therefore, that bringing back more GDNF may be more helpful. And so the question then became how do we get the GDNF in the right parts of the brain? And this is really what has taken the decades to get us to where I'm going to have Dr. Chabria show you where we are now. But you can see there was, cell therapy has been looked at also for decades. And here we have both the cell therapies and looking at putting in the GDNF, just the protein itself, not gene therapy, and trying to do it that way as well. And again, this has been several iterations of how do we get this to make it work and look like it was working well in the animal models. So decades have already gone into this. So again, there's been a decades understanding of GDNF and Parkinson's, and there's just been a real hamper of how do we get the GDNF to the right patients at the right time in the right amount and at the right place. So again, we think that this loss of GDNF may actually contribute to the progression of Parkinson's. We do think that GDNF when it is present, it will actually help keep the cells that are still there, keep them healthier and help them keep working better. And this idea is that we can also have the potential to restore some of those cells that are maybe they're alive, but they're not actually helping very much. They're not doing much for the dopamine transmission per se. And can we make them function better and work better? And so this is really what led to a lot of the development of the study you're about to see with Dr. Chabria. So let me take a second here. I need to describe like how we actually do gene therapy for the brain. So this is brain surgery. And so I don't say that lightly, but I want to show everyone here what this means and what this technology that we've developed and how I think it really is going to revolutionize how we are able to do this and do it safely. And so this actually was technology that was developed primarily by Dr. Chris Bankovich at UCSF. This was basically allowing us to do these procedures in the MRI so that we could see in near real time what we were doing, where the drug was going, where it was not going. And this has really been a revolutionary for us to be able to do this right. So for these studies, there's a extensive screening period. So we want to make sure we've got the right people for these types of studies, and anyone who's been able to pass that qualification process will be invited to participate. The AV2 GDNF, so our study drug, this AB1005. So it's administered directly into the brain through an MRI monitored process, and I have some videos to show you here in a second. This technique, it's 15 years in use in people. And so again, really kind of lending to the safety aspects of our gene therapy delivery. So this is a cartoon of one way that we're doing this. So I just want to point out a couple of things. So this is a brain. So this is the part of the brain that we're aiming for. This is called the putamen. This is one of the sort of downstream ends of the circuitry in Parkinson's that is affected. And this is where we think we're going to have the best benefit with our GDNF gene therapy. What we do here is we use two small hollow tubes. They're called cannulae. And we use these very slowly implanted and then pushed very slowly into this putamen in order to really fill up the structure of the putamen with the gene therapy. This is done asleep and is a one-time procedure, and everything is customized to everybody's individual putamen. And I think that's a really important point, that we're trying to make this customizable for every patient. So this is the current technique that we are using in our current gene therapy study. So just to orient everybody, so there's eyeballs up here at the top, the ears would be off to the side, and you can see this black line coming in the view here. So this is one of those hollow tubes, like the cannula. There is another one on this side, but this MRI is just tilted a little bit so we can't see it. What we're seeing here is some white that is kind of growing and changing. This is actually our study drug. And what we're trying to do is get this white to fill up the putamen, which is this darker gray blob structure you can kind of see here. We want it to go in the putamen and only the putamen. And by doing it in the MRI, this allows us to see and make adjustments in the moment with the surgery in order to be able to make sure we get the drug placed in the right spot and in the right amount. We think that this is really important for Parkinson's in particular. And so you can see here, our goal is we want to get over half of that structure covered with our gene therapy in order to be able to get enough of that protein then made so we have enough GDNF in the areas that where it's needed. I just want to mention that this is actually sped up many, many times. It takes many hours to do this procedure, but I have it sped up here just for so we can see what's going on. So typically, again, there's a lot of process and evaluations that happen on the day before surgery happens at all. But then we have the day of surgery. It's just one day. And then afterwards, there's usually 1 or 2 days of recovery in the hospital. Usually not a whole lot. Patients then return home, and then that's when there's a lot of visits that then happen afterwards. And Dr. Chaudhry will be able to discuss this a little bit more. But we have, it's a busy and an important study really to help us understand if we're really making an impact on overall disease progression in Parkinson's. And with that, I'm happy to hand this over to my esteemed colleague, Dr. Chaudhry.
Thank you, Dr. Van Laar, and thank you guys for allowing us to join you today, and good morning to everybody. We're very excited to be able to present this information to you. So as Dr. Van Laar mentioned, we do have data from our phase 1b study, which is an open label study that was done in mild and moderate Parkinson's disease patients. So in this case, everybody did get the medication. Next slide. So when we look at the patients that enrolled in this study, there were only 11 participants, and we had them separated, as I said, in a mild cohort as well as a moderate cohort. They were about the same age between the two cohorts, and the majority were mainly male. But when you look at the disease, how long the patients had had the disease for the mild cohort, it was about 2 years from diagnosis, and for the moderate, it was about 8 years from diagnosis. And when we look at their MDS-UPDRS off scores, meaning that they had not taken medication for at least 12 hours prior to being examined, it's kind of what we would expect for these cohorts. So somewhere around 20 in the mild and around 40 in the moderate. And then after they'd taken their medication, waited about an hour before reassessing, we did see a dramatic improvement down to about 8 and about 21. And we also saw what we would expect with regards to the amount of medication that these patients would be taking, somewhere around 500 for our mild and around 1,200 for our moderate cohort. Next slide. As Dr. Van Laar already showed you, this is how we actually infuse the medication. And what we were able to achieve between the two cohorts is about 63% coverage of both putamen, which is above and beyond what we were actually looking for, which, as she had said, was greater than 50% coverage. So we were very impressed with what we were able to achieve with this approach of using the bilateral parieto-occipital approach, meaning going from the back of the brain versus going from the front like you would with DBS. Next slide. And so when we look at any of the side effects or adverse events that you would expect when you see when you do these kinds of trials, before surgery, we saw what we would expect. Patients were not on their medicines for quite some time, so there was definitely some tremor. It is a surgical procedure, so we would expect patients to have some headaches because there is a little bit of drilling and obviously the placement of the cannulas. And you've been laying down for a long period of time, so it's expected to experience some fatigue, some muscle aches, and joint pains. After the surgical procedure, we did expect to see some of the things that we saw. Again, fatigue, but again, this was also done during COVID, so we did see some COVID infections. But again, these were things that we expected to see in this type of population and in this type of procedure. Next slide. So this is the impressive thing, and this is what's actually helped us move on to our next phase of surgery. When we look at our assessment of the MDS-UPDRS Part 3 and Part 2, looking at the patients who hadn't taken medication, and then after having taken their medication, when we look at our mild cohort, we actually kind of see stabilization across the board. So you kind of see that there's not really much change in the on and the Part 2. And the Part 3 off actually stabilized around the same as what we had seen as the average across the board. And this is at 18 months. The reason you see this minor uptake at the end at the 18 months is one of the patients in that cohort actually was found to have something called a tyrosine hydroxylase deficiency. And so when you have that deficiency, your UPDRS score when you're off tends to tick upwards a little bit because you're needing more and more and more dopamine. And so that's what we were seeing in that case. Now with our moderate cohort, we saw a dramatic improvement in our off period in the MDS-UPDRS Part 3 of almost 50%. So you see they started around 40, and they actually came down to about 20 with their off score without taking any medication. So they kind of regressed back to what we would consider our mild cohort. And then we also saw that improvement as well in the on score as well as the Part 2. So for that reason alone, just looking at this improvement, we decided that this is the group of population that we would like to look at further in our phase 2 Parkinson's trial. Next slide. And then the other thing that we looked at is the motor diaries. I don't know if any of you have ever done this before, but it's basically where you have to go in every 30 minutes and say whether you're asleep, whether your medicine is working. So if it's on and you're experiencing a good on time, whether your medicine isn't working, meaning it's off, and whether you're experiencing any type of dyskinesia, so those writhing, twisting, jerking movements that I'm sure some of you have experienced, and whether those have been actually troublesome, so they're actually getting in the way of your daily activities. And so what we're actually seeing is that those patients at baseline, and we're specifically looking at our moderate cohort in this database, is that they did have some troublesome dyskinesia, but they had a marked amount of off time at almost 4.5 hours. Um, and we did see after 12 months that there was an improvement of almost 3 hours in their on time and a reduction of almost 2 hours in their off time, as well as a reduction in their troublesome dyskinesia. And we've also seen that going into the 18-month as well, with some patients even being able to reduce the amount of levodopa that they were taking, and also the reduction of their adjunctive therapies that they were taking as well. We do see a slight uptick in the off time. Or actually, we see even more dramatic improvement in the off time to now actually 50% improvement in the off time. And so this is remarkable, and we hopefully will be publishing this data soon. And then hopefully soon we can actually get you even more data, given the fact that these patients have been in the study for quite some time at this point. Next slide. So what does this mean? So basically what we're saying is that, yes, we know this is an open label study, and yes, we know that Parkinson's patients do have a very large placebo effect, especially given the fact that, the placebo affects the dopamine pathways, and so that actually makes you happy and it makes you feel like you're getting better. But now that we've actually seen this 18-month data, and we actually have even more data going out to 36 months, it's possible that that placebo effect is no longer actually an issue. And so it's made us decide that we need to go on, and we are going to be following up these patients up to 5 years and potentially even longer after that. So from that, what we've seen, we've decided to move on to a phase 2, which we now call Regenerate PD. Next slide. So that's what I'm going to talk to you about. So Regenerate PD is our phase 2 double-blind placebo sham-controlled study. So basically this means that if you participate in this study, there is the potential of not actually getting the actual procedure. So you actually get a little bit of, you do undergo drill holes and the same setup as a patient who is getting the active procedure. However, you will not get the medication. And so the way this study is designed is we are looking to enroll 87 patients. So we have a 42-day screening period. And then we go through what's called an eligibility review panel. And so we go through all of the information that's provided to us. And as a team, we decide if we can proceed you to the baseline procedures. The baseline is anywhere from 3 to 6 weeks. And then after you go through baseline, which is some assessments and imaging, you then go into the randomization phase, where that's the surgical procedure, and you either have a 2-to-1 chance of either getting drug or getting the control surgery. It's a one-time procedure, as Dr. Van Laar has said. And then once you're done with that procedure, you are then sent back to your neurology office, and you are seen every 3 to 6 months until the last person is completing the 18-month follow-up visit. Once the last person completes the 18-month visit, we will then unblind the study, and we will look at all of the information. And then if we deem the study to be safe and the drug to be safe, we will then offer those who received the control surgery an opportunity to go into the open label extension and actually receive the active treatment. There will be a separate protocol for that, and you will need to be able to qualify after you complete the 18 months. And those who did receive the active will then go into our long-term follow-up and will be followed up for 5 years. Next slide. So here are some key patient selection criteria. So these are not all of the criteria. This is just some of the criteria that we are looking at. So we're looking for patients who are 45 to 75, male or female. You have to be diagnosed with Parkinson's in the past 4 to 10 years. We are looking for motor fluctuations with significant hours of off time. And as you saw in our data from our phase 1, the moderate group did have about 4.5 hours of off time. So they did have a significant amount of off time. Your Parkinson's medications need to be stable for at least 4 weeks prior to your screening. And we need to make sure that you actually do respond to levodopa. From an exclusion standpoint, we are looking for patients who have idiopathic Parkinson's, and if we know that you have a medical cause or genetic cause or any other neurological cause of Parkinson's, you'll be excluded from the study. We are looking for patients who have good cognitive standing and no psychosis. and you cannot have gone through previous brain surgery. Next slide. So this is a map of where we have our sites. These are not all of the sites. We actually have a few more sites that we are adding on to on board. But for you all, the closest site for you would be the University of California, San Francisco, which is a combination site for us, which is actually a surgical site as well as a neurological site. And we are doing this study also in Europe and the UK. Next slide. So if you are interested in participating in a clinical trial, we have some ways for you to get there, and we do have some links that we're going to put into the chat so that we can help you find this study if you are interested. The first thing is talk to your neurologist or your movement disorder specialist, whomever you are seeing for your disease. This is the person to talk to and see if they give you some input as to whether or not you want to proceed with this study. The next is clinicaltrials.gov. And like I said, we will give you the link for our study at clinicaltrials.gov. If you can't get to it from clinicaltrials.gov, you are able to get through it on the Ask Bio website. If you just click clinical trials, it will take you straight to the clinicaltrials.gov site. But this is what you can find when you go to clinicaltrials.gov, and where it says other or in conditions, you can either type in Parkinson's disease or gene therapy. And then in the other terms, you can write Ask Bio, or you can write gene therapy. And then the other way to look for our study is through the Fox Trial Finder, and we will also give you the link to that as well. If you go to foxtrialfinder.michaeljfox.org, you can go in there and type in Ask Bio, gene therapy, Parkinson's, and you'll be able to find our study as well. But you should have all the links you need in the chat. And who are we? So who is AskBio? Well, we've been around for a really long time, even though we're a very tiny company and most of you have never heard us. We've been around since 2001. We have offices throughout the world, and we are now a company that is going to go into the brain, but we also work in muscle, respiratory, and in the heart as well. Next slide. So one of the best ways to get a hold of any of the sites in this study is to go through our patient engagement, which is Ask First. You actually get, you'll send an email to askfirst@askbio.com, and you'll actually get a live person who will respond to you and can give you some information about the study, where you can go to actually participate in the study if you're interested. It's a great resource if you're interested in participating in our clinical trial. Next slide. So like we said before, talk to your neurologist. You can use the links that we provided, or you can try Ask First at askbio.com, and they are very helpful and can get you all the information you need regarding Regenerate PD. Next slide. So we really encourage you to participate if this is something that you think would fit your lifestyle and your Parkinson's disease. So please consider joining the fight. Next slide. And we give a special thanks to all of our clinical trial participants. And that's all. So if you have any questions, we would love to answer them for you.
That is terrific, Amber and Nisha. Thank you very much for that. That's super interesting stuff. What is gene therapy and how you're going about it is captivating, a little bit lofty and heady for me and some of us maybe. So we'll keep fielding these questions. If folks have questions, this is the time to start lobbing them into the Q&A tool that can be found at the bottom of your Zoom screen in what's called the tool tray. You'll see Q&A with a little question mark in a box. That's your go-to place for lobbing in questions. And then the trial, wow, very interesting. So I actually have a couple quick questions that I'll lob out, and if Gabriel does, he can fire away too. But my first question is, and I may have missed part of this as I'm scribbling notes. Why target the putamen instead of the substantia nigra? I mean, is this because we're worried more about targeting the less worried about targeting the neurons that create more dopamine cells, or?
So I'm actually really glad you asked this question, because this is a nuance of what we're doing that actually makes a big difference. But it's actually a little hard to explain. So bear with me.
Yeah.
So we know putamen sort of downstream, right? But this is where we have most of the loss of the processes. So our ability, the little branches are being lost here mostly. And we happen to know that GDNF is really good at making those branches grow back. We've seen this not only in our animal studies, but we actually have a very limited amount of postmortem data from patients that actually show us the same thing. We get more sprouting. With more sprouting, this means that we're able to, enhance those cells that are still there. We're able to make them work a little bit better, and again, help with dopamine transmission a bit better. Now, one other amazing thing though is that the brain is connected. All these networks are connected. And so there just happens to be a network that goes from the putamen all the way back to the substantia nigra. And we're taking advantage of that existing highway. And our drug actually does go all the way back to nigra. So it goes back to pars reticulata. So it's just underneath the part of the compacted that's most affected by PD. But the nice thing is GDNF is made and it's secreted. And so even at the level of the nigra, we do get the benefit of GDNF. Now, from a surgical standpoint, it is a whole lot easier to get to the putamen than it is into the brainstem and where the midbrain sits. It's very dangerous. It's very cramped. It's hard to get there. And so from a safety standpoint, this makes a whole lot of sense. And it also allows us to just get a lot more of our gene therapy in there as well. So lots of reasons behind it. Thank you for asking that.
Great. Tell us a little bit about how this surgery, which sounds similar in certain respects to DBS, but how does it differ from DBS in terms of complexity, duration, recovery?
Yeah, Nisha, why don't you take that one?
Sure. So first, the difference is the approach. So when you go with DBS, you're actually going through a frontal approach. With ours, you're actually going through a bilateral parieto-occipital approach. So we're going from the back. So the reason we do that is in our phase 1, we actually did use a frontal approach to be able to get to the putamen, but we weren't able to get enough coverage of the putamen using that approach. By using the occipital approach or bilateral parieto-occipital approach, we're actually get more coverage to the putamen, as Dr. Van Laar showed. And also it's, mainly just so we could get more coverage of it. Now, from a time of surgery, it can take anywhere from 6 to 10 hours, depending on the surgeon who's performing it. You start by going under anesthesia. Well, first they get anesthesia. They have to get you fitted into the frame to be able to go into the MRI machine, because we do need the MRI guidance to make sure that we actually get the right location. And then again, depending on the surgeon and how they infuse, there is the infusion time that can be a couple of hours to 4 hours. And then, they get you out of anesthesia and get you to the PACU to recover. And then usually you're in the hospital for about a day and then they send you home. For our study, we do have follow-up with the surgeon, so you don't actually physically go back home to your home until after that visit with the surgeon, which can be anywhere from 3 to 5 days post the surgery. And then you're able to travel back to your home. For those who are in the Bay Area, you would be able to go home, obviously, because that is, UCSF is pretty close to Berkeley and to Oakland. So in that case, it's not as big of a deal. And so that's really the difference. And then the main difference is there's no hardware left behind. This is a one and done procedure. And we just leave drug in the brain and that's it. So there's no wiring, there's no pacemaker, there's none of that, which
But the
is
little medical feeding tube is not retracted.
It is. So the only thing that's left behind is the gene. That's it. Everything else is gotten rid of. Yeah.
Now I see. Interesting. Okay. So it's invasive,
Can I?
but you're removing hardware, so it's less risk in that regard.
And that means no more repeat surgeries. There's no batteries to replace. This is it. It's a one time. Do you want to speak a little bit to just the recovery on that? And
yeah, I mean the recovery seems to be pretty rapid. For the couple of patients that we have right now, they've been able to go home pretty soon after their surgery. Again, like I said, you do have to do a follow-up with the surgeon, and there's some blood work involved that has to be done before you're able to travel back to your home. But usually they're back within 3 to 5 days of the surgery, and usually back on their feet feeling like themselves by the next day of the surgery.
I would say most people I've talked to have gone through this. It's the anesthesia. And so if you are someone who has a hard time with anesthesia, this would also be hard. But we take a lot of precautions just like you would with DBS. So there's really nothing different that we would do there because it's gene therapy per se. But because there's no hardware, that actually does help with recovery a bit. But most people are really, I kind of judge it based off of when they can restart their exercise routine. That's usually a good way to call it. And usually that's like a week or two is when I think most people are, really kind of back to their normal routine. And again, most of it's because of the lingering effects from anesthesia.
And I imagine removal of
There's a
hardware
couple-
also reduces the risk of infection post-operative.
Correct. Absolutely. Yep.
Go ahead, Gabe. Sorry.
There's a couple questions. No worries. There's a couple questions about exclusions. If somebody has DBS, or if they're over 75, or they have more than moderate symptoms, are there any alternatives that you can see for them to participate in something down the road?
Not with our gene therapy, unfortunately. Now, for the more than moderate symptoms and under the age of 75, we may potentially have another study coming into the works for those with advanced Parkinson's. However, our age limit cutoff is 75 for all of our clinical trials, unfortunately. Now, the question I see about I have DBS, would a phase 3 be done, and would the FDA let people get this treatment? We are going to be doing a phase 3 again if we deem our phase 2 to be safe and effective, obviously. We won't allow DBS patients in that study either. But after it's FDA approved, that's a whole different beast. So
I need to add, the reason is we can't actually see where we're going if the DBS is in there. This is really the
Also
problem. The other issue is, we have the MRI running for hours. So though there is now MRI compliant DBS devices out there, it still is going to be an issue with how we're using the MRI for this particular procedure.
Interesting.
If I
And you
go
talk
with
about
another
this
one,
as
Todd.
Yeah, go for it.
Yeah, go for it.
Go, Gabe.
There's a great question about, does this procedure really reverse the damage done by PD? Is it, or is it slowing it down? Because you said something about the moderates actually being able to reduce some of their levodopa intake. Curious to hear more details about that.
Let me just get on the first part. So, I mean, this is where, again, one of my first slides is how do we show disease modification? I mean, this is a real hard part for any drug. But with GDNF itself, I think it's important to point out, I don't think this is making new cells. That's not how this is working. But what we do think is that it's helping with that sprouting, and that is what is causing some changes in the overall trajectory of the disease. We can see this then in how patients are performing clinically. So we can see their UPDS scores are going from where they were at baseline and now going back to where they were they're almost at where they were for our mild group. That tells us that there is something working there, and then to be able to get the improvements on UPDRS with less levodopa, I think also just speaks to the fact that we really are improving the way that dopamine is being handled in the Parkinson's brain. In order for us to be able to really get at this, we need more patients. We need more data. We need to see what this drug is doing in more people with more varieties of Parkinson's. But what we can say from, again, decades of animal studies, a little bit of our early GDNF studies, that this really is impacting the ability to handle dopamine. And we think that's because we really are impacting the underlying anatomy here. Now, how we show that is going to be difficult, but between how patients are doing clinically, plus imaging, plus a few other things, and time, I think is how we can really show that in fact we are impacting disease progression.
Great.
But Nisha, please add in if you've got anything.
No, you pretty much said it. I mean, our goal is to resprout dying, not dead dopamine cell producing cells. The dead ones we can't do anything about, unfortunately. So disease slowing is really our goal, is what we're trying to do. And we did sort of see that in our phase 1b data. So
Good. Okay, and our very own Monique asks if there are any potential side effects of the gene therapy itself, not so much the surgery, but the drug.
to date, no.
Good answer, nice and short. We like that.
I'm going to caveat that with sometimes we see dyskinesias kind of pop up, and that's usually a sign to us that we need to reduce meds, and that is also evidence that the drug is working.
Interesting. How closely do you work with a neurologist in terms of like managing the meds and that sort of for the patient?
Good question.
You take
That's
that
all
one
you.
because you've had more
No,
experience.
no, that's all you.
In all honesty, as of right now, we've been leaving it to the PI, the principal investigator, to make that determination with the patient as to whether they feel the patient should have their medication reduced. Some patients choose to do it on their own and then tell the PI later that they're planning on doing that. So it's dependent on the patient and the principal investigator that they're working with.
You gotta trust. I mean, no one knows their Parkinson's better than themselves. Like and I think most neurologists, both Nish and I are movement disorder specialists. Like I really let the patient guide, a lot of decisions like that. And most of our investigators are the same way. Again, if you see something like dyskinesia coming up, that's usually an indication we need to start dropping levodopa a little bit. So this is really sort of a mutual thing. Now, that being said, this is things that are being done in a clinical study. We want to know everything that's happening so we can keep track and better understand what's going on. But the goal would be to work with your local neurologist and at least let them know what's going on. But because this is happening in a study, it's really important that we know all the changes that are being made.
Yeah, makes sense. And we've talked about GDNF in the context of PD specifically. So Robert has a good question to branch out from that and ask about how helpful GDNF might be to a PD variant such as PSP, which is progressive supranuclear palsy, and any others that might be unresponsive to levodopa.
So we actually have a multiple system atrophy study for really partly that reason. Mm-hmm. Now, MSA is unique in that it is a GDNF deficient state. So there's one of the main causes in what I can see in the literature, one of them is synuclein and this loss of GDNF. So it made perfect sense to go there. We're still in the middle of the study, so I don't really have a whole lot to say right now because it's blinded. But I have wondered, about the other Parkinsonisms. The concern I've had with the things like PSP and CBD is that these are tauopathies, and inherently the biology there is just a little bit different. We do think that GDNF is actually quite good for the synucleinopathies, which is, again, part of why we think MSA is a good target. We have seen some benefit on reducing the amount of synuclein burden with GDNF, mostly in cellular work. So I think that there's an added benefit to think more of like on the synuclein pathway. So, DLB, I think should be on that list of things to consider.
Good.
I love that question.
Yeah, that's a good one.
So is this exclusionary of other treatments, like if somebody's doing stem cells or any of that?
Yes, this is exclusionary. Basically, if you participate in this clinical trial, you are excluded from pretty much any other clinical trial from now on. So for that person who's questioning, can we do stem cells and do gene therapy? It's one or the other. And so that would be a discussion to have between you and your MDS or your neurologist and to determine which one might be the best option for you as the patient.
And for somebody in the Pasadena trial as well, they would be excluded.
Yes, they would be excluded. If they're currently participating in the Pasadena trial, they cannot do both. If they are out of the Pasadena trial and it's 12 weeks have passed, then they can participate in our clinical trial. But there has to be 12 weeks minimum between one clinical trial ending and starting this clinical trial.
This is so complicated. We can't figure out what's happening in one other experiment in our experiment. And so this is why we really need to keep it very clean.
And are there open doors like that? You referenced that open communication channels so that scientists can learn from other trials going on out there? I mean, pre-conclusion. Or is that
So
hard to do?
I think actually it's interesting because we're working with, so Michael J. Fox is a contributor, but there's a group, so there's the Critical Path Institute, I think is a good example of, this is they have a focus group, a whole consortium around Parkinson's. And the whole point was that we have all these studies going on. How on earth are we sharing these learnings so that we can actually speed up and do better for our patients? And so we are working with this group, and this idea is that there's shared learnings here. So are there better trial designs? Are there better endpoints that we should be using? Are there better ways of assessing patients? So this is a big effort that we're taking on. It's not any one thing. This is a shared effort. There's other big pharma that's in there too. And I think, the fruits of this we're going to see in the years to come, but we really need to start thinking about, maybe our endpoint should be different, or the way that we're looking at this should be different because we're doing a regenerative medicine. And this is a great way to start asking those questions in a non-competitive space.
Before we continue, can I ask for a favor, Todd? Can we add Aaron Daly as a panelist? He's the clinical research coordinator at UCSF for this clinical trial. So if you guys have any questions, he can actually answer some of those questions.
Done.
And it's in the chat.
Thank you.
Awesome.
I think it's
So
done.
there's a question about why are
Aaron?
patients with genetic
Here's Aaron.
mutations linked to PD excluded from the trial?
So there was a question that came in with that. So again, it's the same sort of idea. If we think that there's an underlying genetic cause, in some cases, we think that it's just a different flavor of Parkinson's, and that may not translate then to all other comers with PD. So again, it's really just to kind of help us understand for the average, idiopathic Parkinson's, does this make sense? That being said, I do think that there may be, potential benefit down the road if we get, better understanding of what we're doing here. Is there a room to look at, certain genotypes? I think that's reasonable. But right now, just so we just need to understand what's going on with this drug. So as part of just development and getting approvals.
Gotcha. I know this is a murky crystal ball question, but any sense of how long until drug approval if things go well?
As of right now, we're aiming for 2032.
$1 million question.
Yeah, I know. I wish I wish I had that crystal ball. This is actually a really important topic, and maybe people have maybe seen some of this come across. But when it comes to gene therapy specifically, it has been recognized that maybe we shouldn't be having to go through some of the same stepwise procedures as something like a small molecule that needs hundreds of patients. So this is, we're actively speaking with the FDA and others, and again, the Critical Path Institute, trying to come up, does this make sense with what we're doing? And even with something like a sham surgery, I think we need to really be working with our regulators and our neurologists and patients when we are actively working with patients and their families too. Does this make sense? And so this is an ongoing changing story, but this right now, it's a slow process, and in large part because Parkinson's is also slow.
Tell me about it.
Insidious.
Aaron, thanks for joining us. There's a quick sidebar question here. If you wouldn't mind, if you've got a minute to put into the chat window the eligibility requirements for the trial, is that, or do you guys have a slide that I missed that speaks to that specifically, Amber?
We had a slide that gave a small selection of the inclusion criteria and exclusion criteria.
Yeah.
I would probably rather post my email address, and I can send people the inclusion exclusion criteria specifically if they're interested in the trial.
Okay.
Perfect. Thank you, Aaron.
Thanks,
You
Aaron.
may be able to do that through chat, Aaron. Let me double check here. Carry on.
There's just so many nuances, and again, we're really just trying to find it. Say again?
You want to run through the criteria again real fast for everybody since the slide's up?
Yeah,
some of the key ones. Yeah, go ahead.
So 45 to 75 years of age, male or female, diagnosed with Parkinson's in the last 4 to 10 years, have to have motor fluctuations with significant hours of off time. PD meds need to be stable for at least 4 weeks prior to screening, and we need to know that you are responsive to levodopa. Key exclusion criteria is that you have to have idiopathic Parkinson's. We are not looking for genetic or medical causes for Parkinson's. No history of cognitive or impairment or dementia or psychosis. And as stated previously, no previous history of DBS. Or I guess even I should not just DBS, but also what is it called? Focused ultrasound. That also would be exclusionary.
Gotcha.
Why do you think that is?
Have you had any?
Focused ultrasound
Go
involved
ahead, Don.
hardware that might get in the way of a surgical treatment, GDNF?
It's ablative, and again, it's like we really don't, we just don't know. We have no understanding. And the other concern is, depending on how and what it looks like, it may get in the way of us being able to find a safe trajectory to get to the right part of the putamen.
Yeah, and if we're talking about brain surgery, let's just rule out any possible concerns, right? So
we actually have way more exclusion criteria, primarily to make sure people are safe for surgery. We got to make sure that we don't, again, there's too many other things going on. We need to make that as safe as possible.
Yeah, I hear you. John asked the question of how to save the chat. Thanks for reminding us, John. We will, by the end of this session, walk you through that. It's a very simple little process, so hold tight.
Another question came through is, have you had any patients who have gone through the GDNF and then gone on to get DBS after?
That's a good question.
Actually, there's one, and this was, I didn't have time to go into it, but there was the very first gene therapy with GDNF study was started in 2013 at the NIH. And this was actually looking at patients with advanced disease. They were on average about 12 years from diagnosis. And I think it's actually interesting that given all of that, there was only one participant that went on to go and have DBS. I think that, to me, that says a lot about what we may be doing with the overall disease course. With 13 participants, only one went on to go get DBS. The rest were just with the GDNF gene therapy.
And that was conflict-free.
Oh yeah, no, this was well after. I mean, that was 5 years after. I mean, so it was many years after the procedure. So, and again, I think it also kind of speaks to the gene therapy, and that was also using a much lower dose and a different type of delivery than what we're doing currently. Yeah.
We actually have a second one. The subject that I said that had the tyrosine hydroxylase deficiency, she actually underwent DBS recently. She just had it done in October of 2024.
Interesting. So it is feasible to go from one to the other, in other words, GDNF to later DBS, but not vice versa.
Yes, not the other way around. Correct. Yep.
That's important for folks to know.
Yes.
Let's see. Here's one from someone. How do you think the efficacy of GDNF therapy in the context of the alpha-synuclein seeding hypothesis? I'm not sure I'm reading that correctly, but what makes you say you only need one GDNF treatment?
So I think there's maybe a couple of thoughts there. So the seeding amplification assay is really placed right now and good at saying, you've got the type of synuclein that suggests you're probably going to go on to get something like Parkinson's. So for us, we are including people that we already know for sure have Parkinson's. So I think that's that one piece. Now, there's really not a good way to assess how much synuclein someone has. We still don't have that imaging. We don't have that blood test, not really right now. And so it's not easy for us to test this after our GDNF gene therapy per se. So we are trying to do these sorts of things, but it's not so easy. I don't know, Nish, do you have anything to add?
Nope.
Okay.
There was a question earlier about GDNF, and it sounds amazing in its potential. How come we haven't heard of it?
Oh, it's funny because I do think some people may have heard. It was really hot and a hot topic in the field in like the early 90s. Like there was a lot of interest right about then. And then I think when they first started trying to put the GDNF protein into the ventricles, there were problems with that. And I think it kind of just fell out of favor for a while. And then really, it's just, I think it's been a couple of groups have been working over the past couple of decades. Again, how do we get it in the brain in a way that's safe and helps? And we've just been quietly working on this for decades. And so here we are. I think, it's sometimes we actually face the, GDNF, it's already been tried. What are you doing? So hopefully we'll start having the conversation about GDNF a little bit more now.
Gotcha.
Great. Continuing back on the thread of sort of DBS surgery versus GDNF, or sequentially which one can come first or can't. Rick asked if someone having had DBS really wanted to try GDNF for reasons that I don't know about yet, but couldn't they remove hardware from the DBS exercise and revert back to a GDNF process?
I'm giving that one to you.
Maybe
Um,
a thin use case, but
So in all honesty, if you've actually undergone DBS at this point, I feel that your disease progression is probably more advanced than what we are looking for in this clinical trial. And also, I really don't know any surgeon that would remotely choose to remove the hardware. Generally, if the DBS isn't working, they could tell us to just turn it off. And I've had to do that for patients in the past. Most surgeons don't like to meddle in the brain if they don't have to. And there's definitely risks with removing DBS just as much as there's risks with putting it in place. So I would probably not recommend removal of DBS just to participate in this clinical trial.
that seems logical.
Does exercise generate GDNF?
It
yes.
does. It does, but not at the levels that we're able to produce with our clinical trial. So exercise doesn't just produce GDNF, it produces BDNF, it produces quite a few of the different proteins that we know help with dopamine production. We're helping those dopamine cells that are still alive produce dopamine. But the amount that is made just doing exercise alone is not equivalent to the amount that we're able to produce by putting the transgene into our cells and having it being read by our cells.
But that is why we think exercise is helpful in PD. It's one of the reasons
Neuroprotective.
why. Yeah.
Exactly.
And actually we ask in the study just if you're already exercising, keep exercising the same amount. Don't all of a sudden start really picking up exercise, because it's another confounding factor for that exact reason.
Interesting. So it's kind of like a turbocharging what your exercise would be doing.
Mm-hmm. I mean, it's highly recommended that our patients move as much as they can every day. And obviously we tell them 30 minutes a day, 5 days a week, or 45 minutes, 3 days a week. But honestly, if you can do anything that you love, I don't care what it is. It can be Tai Chi, it can be pickleball, it can be walking, doesn't matter. Just do what you love and get yourself moving, because that's really the best way to help this disease. And we know it's the only neuroprotective mechanism we have at this point to be able to slow down Parkinson's.
And of course, if you have gone through GDNF, the recommendation would be to continue any exercise protocol you're working.
Yes.
Correct. Yep.
And actually, we are going to be documenting and tracking that in this study, actually, to see if we have, better improvement in those that actually do exercise versus those that don't. So.
Say, let me detour for a second here and ask Aaron, since we've lobbed you into the panelist role here, maybe you wouldn't mind introducing yourself and your role at UCSF.
Sure, no problem. Hopefully some of you already know who I am, because I also do outreach and education in the Bay Area. I do work at UCSF, but you don't have to be seen at UCSF in order to avail yourself of my services. If you need connection to community resources, support groups, help getting into UCSF, any of those things, I am sort of the first person you should contact if you need help in anything in the Parkinson's realm. I worked on the GDNF phase 1 study, which is now in long-term follow-up, and as well, just the cursory of the first round of GDNFs that Amber spoke of earlier. I don't know. It's a good team. What can I say? We'd be happy to have all of you join us if you feel like this is something that you'd like to do.
Great. You're all lucky to have Aaron there. That's all I can say.
we've known about Aaron for a while at PD Active, but it's nice to see your face, Aaron. Thanks for being willing to join us as a panelist and answer any questions. And we've put a few links in the chat, which is now growing at least as long as my leg here. But if folks scroll back up, they will find links to websites where they can learn more. And of course, we recently pasted Aaron's email itself into the chat. I suppose, Aaron, if it's okay, folks can lob you questions about the trial and involvement options.
Absolutely.
Great.
Okay. Herbeck asked a good sort of foundational question. Does your protocol require FDA approval?
Oh, yes. Everything we do, and I actually want to make a point about this. Any clinical trial worth its salt will be on clinicaltrials.gov. It's required for them to be there. We also cover cost of these things. I mean, these are all the things that should be done for a legitimate clinical study. So yes, the FDA has seen all of our work and all the prior work, and this protocol did have to go through their review.
Ellen asks for a little bit more elaboration on exercise and how it can be neuroprotective.
So there have been clinical trials that have been done looking at different various forms of exercise. So the earliest trial that was published was the one from the Cleveland Clinic, where they actually looked at tandem biking. So they took a professional bicyclist and put a Parkinson's patient on the back of a tandem bike and looked at the motor UPDRS scores based on how active the patient was with the tandem biker. And just the motion itself of moving your legs on the bike with the bicyclist showed a reduction in the motor UPDRS scores. And so that is what we use a lot of times as a marker to show an improvement in Parkinson's and slowing it down and trying to bring it back, kind of like what we're seeing in our moderate group, where we had patients starting at 40 in the off, going down to 20, which when we looked at our mild group was where they started. So these patients then were kind of regressing back into a more mild form of Parkinson's. And so all clinical trials that have been done with looking at different various forms of exercise, whether it's bicycling, walking on a treadmill, walking outside, all of that kind of stuff, they're looking at that motor UPDRS score and looking at the improvement that's there. And because we know that it works in similar methods as GDNF, BDNF, all the things that we need to help regrow dying dopamine cells, we're able to see that there is an improvement and a slowing of the disease itself. And Amber, you can feel free to add to that.
Oh, no, it's great. It's perfect. I just, this is why exercise is so important and why I would always push my patients to take this on, because they're really, the idea is that these are trophic factors, meaning that they're like food for the brain cells. And this is how they protect, is they just improve the overall health of that cell. This is again what we're trying to do with our gene therapy.
So I'm curious, why is it a one-time treatment versus could it be every 5 years, every 10? Is that TBD?
Oh, yeah, no. So actually there's, we're studying this right now. This is part of what we're trying to evaluate. So what I can say is we have had monkey studies where you can give them the same drug and you follow them out for 8-10 years. The only way to know for sure if it's still there is to look directly in the brain. And I can't do that for people while they're still alive. And so I can say that after 10 years of looking in postmortem with monkeys, that we can see that it's still there, it's still being made, it's still looks just like it should have if from day one. Now, we also have very limited postmortem data from that phase 1 study I mentioned from the NIH. So many years ago, there was a patient who had, many years after a procedure, he had an elective back surgery and passed away from complications of the procedure. And so we have this brain tissue, and this was several years after his procedure. I think it was like 3 or 4 years. And we still see it. It's still being produced. We can see the sprouting. So again, all these things that exactly what we were seeing in the non-human primate data. So we also know that the brain isn't making new cells. Therefore, that the gene that we put in there should still be there. Those genes don't go away. So we have good reason to think, just because of how gene therapy works and how DNA works and how cells in the brain just don't turn over. These are also reasons why we should have potentially for the lifetime of a person and don't need a repeat surgery.
Excellent. So you kind of answered an earlier question we had that I was kind of saving for the right moment, which is the autopsy question. So that actually is a thing that you were able to do.
I actually think that's really important. It's hard. It's hard. And this isn't for everybody. I know, but there's really only one way for us to really understand what we've done, with gene therapy. And because it's in the brain, we can image. I can image, to the cows come home. But at the end of the day, for me to really see, is there synuclein? How many cells are there? How much sprouting is there? I need to be able to look at the brain itself. And this is where, we do have these conversations. We ask our investigators to have these conversations because I think it's really important for us to be able to get that tissue, long time from now.
Yeah. Interesting. Okay. We have a question here that speaks to motor versus non-motor. Does the therapy help with non-motor and with motor symptoms, and does it affect one more than the other?
We do look at both, and we've been looking at both motor and non-motor symptoms, and there's definitely a more dramatic improvement in motor symptoms that we've seen, but we have seen either stabilization or some improvement in the non-motor symptoms. We are doing assessments looking at the UPDRS that assesses for non-motor symptoms. We're looking at the NMSS, which is the non-motor scale. We're also looking at quality of life measures as well. And we have seen improvement across the board in all of these scales. But there is a more dramatic effect on motor versus the non-motor. But we'll know more. We'll get to know more, obviously, going into this phase 2 double-blind study, because now we'll actually get to look at those patients who didn't get the drug versus those who did, and see if there truly is an improvement as in this group of population.
Now, bear in mind, like for cognitive issues, for example, this is something that worries a lot of people. Now, that being said, we're only enrolling people right now that don't have dementia. So we actually want to see that they're not getting there, right? Which is a lot more boring, and the lines are a lot more flat. But this, if you look at it that way, we want to see no change. Can we preserve what you've got now? But unfortunately, that takes years for us to be able to demonstrate that. And it's not as exciting as seeing these, big changes in your motor scores. But this is, very important for us to be looking at this. And sleep is another one I want to mention as another important part that we're looking at.
Can you say more about that? More about sleep?
So, one of the most common early symptoms is, this interruptions in sleep. Sleep will ruin your day if you don't have, good night's sleep, right? It impacts so much. And for almost, I don't know a patient who hasn't had a problem with sleep. So I think it's been something that's been maybe ignored or not really looked at much in prior Parkinson's studies, because it can be hard to do. Either you're just doing questionnaires, or you need to go and do like a real sleep lab, and that's a lot of work, and it's hard. No one likes it, right? So I think really with the advent of the wearables, and they've gotten really good at monitoring sleep and measuring, phases of sleep. And really at the end of the day, how much are you asleep? How much are you moving around in sleep? All these things are really important, especially for our Parkinson's patients. These are all the aspects that we're going to be looking at, in addition to the traditional scales and things that have been done before. But I think that the technology has gotten to a place where we can do better at, how are you sleeping at home on a day-to-day basis. Just to point out, I do believe that just having more stable dopamine levels in general, it will be helpful for sleep. We've seen this with DBS. We see it when people get better, with their medication regimen. And because we think we're doing the same thing with GDNF, I would anticipate to see changes there as well.
Got it. Okay, great. Joe is asking for a little bit more clarity around the benchmarks, 40 versus 20. I'm not sure what those numbers are. Maybe I missed that slide, but for a person with Parkinson's, is it possible to or feasible to obtain this reading themselves? They have to go through your offices, your process.
I'm not sure I understand.
I may not either. Yeah, Joe, if you've got a second.
The 40 to 20, the reason I keep using those numbers is because that's what we had as our numbers in our data as seen on this slide. So when I say 40, I was talking about the average off score for those patients in the moderate group was about 40. So when you go in to get your assessment done by a movement disorder specialist, they'll have you do silly things like tapping your fingers and opening and closing your hand and tapping your toes and standing and walking. And every single one of those assessments has a number of 0 to 4 attached to it. And so 40 is a number that comes from looking at all these different assessments and then assigning, like I said, a value of 0 to 4 to that. And then the 20 is that we saw them improve so much at 18 months that once the GDNF took effect and it started regrowing those dopamine cells, just by being off, meaning when your medicine isn't working anymore, they had that much of an improvement going from having trouble moving and doing things when they were off to maybe being able to do a lot more in the off state than they probably could have done in the past.
But I think part of the question too is, can you do this on your own at home? And the answer is no. To qualify and to get these scores, it absolutely must be done by a trained movement specialist.
Okay.
When I look at this chart, it looks like for that moderate cohort, they see immediate effects, positive effects that really start to all the way until about 12 months and where it seems to stabilize at about 12. Is that true?
It is not immediate. And I actually am glad you brought that up, because this is kind of deceiving, because there really were several other visits where it was kind of flat and then it gradually comes down. And that makes a lot more sense and actually helps us think that maybe this is not all placebo effect. So we anticipate with gene therapy, it takes time. We have to, the gene has to get into the cells. It then has to get to all the cells. It then has to get read. And then it finally takes time before it's being read and enough of that protein is being made. All of that can take months. And so, and then the body has to kind of react to it. And then there's sort of a rebalancing that I think ends up happening after the transgene, that the GNF expression gets up to its optimal moment. So I don't really expect to see much until after 6 months. And in fact, this is, I think it's really important, because unlike BBS, where you can get almost immediate response as soon as it gets turned on, we expect that gene therapy is going to be a slower on, but it's also going to last a whole lot longer.
Got it. Good. Let me just sidebar here with the tactical matter. I can see that folks are a little bit confused trying to save their own chat. It may be that attendees are unable to save chat, so my apologies for steering you wrong. I do assure you that by the end of the session, I will be saving the chat, and we'll include that in an email that goes out following this session in the next couple of days. So we will make that available to you with all the information in it. So Herb has a quick question. It seems like what you're doing is reactivating the dopamine making capacity of the brain. And he and I will agree that's oversimplifying, but that's kind of what it sounds like. Have there been any studies comparing your protocol with dopamine pumps?
No,
Yeah,
not at this
yeah, no.
time. No, because so in the United States, the pumps just became available, meaning the subcutaneous pumps. I mean, we know we have Duopa that's been available in the US, but technically the subcutaneous pumps literally just got their approval last year, like late last year. And so this could be something that, as a phase 4 trial that the FDA may require us to do in the future. But right now, because everything technically is still in clinical trial phase, there is no comparison that's going to be made.
Fair enough.
And I also just want to point out, we really want to be looking at this as a disease modifying therapy. Levodopa by itself cannot do that.
Exactly.
Yeah. Yeah, that makes sense.
John has an interesting question, kind of comment, which is because of the blood-brain barrier, this is the only way to deliver GDNF. There's no pill potentially down the road.
Correct. Again, this is why decades, 1993 is when we figured out GDNF was maybe this really kind of like amazing, miracle for dopamine cells. But it's funny. It's this little protein, and it really needs to be made by those cells in order to work properly. So they found actually when we make protein, on our own and then give the GDNF that way, it doesn't work the same. there's just, the body is just really good at packaging and making that GDNF so that it works more efficiently. And this is another benefit of doing gene therapy, because you're getting endogenous GDNF that's made the way it's supposed to be made, and then, and packaged so that it's sent out and works better than what we can make in the lab.
Makes sense. Okay, Rob has another question. I think he's reshaping a question asked earlier to see if he can get a different answer out of you guys. When do you think this will move from the experimental stage to a treatment that your neurologist has available to prescribe?
It's years. It's just years. It's years and years and years. We have right now, again, regulation is just so tight. This is brain surgery. They don't take this lightly, and they shouldn't, right? So this is what we're looking at, our endpoints are years down the road. So all these steps just take years and years. So please be patient with us.
Yeah. Fair enough. While our questions are slowing down, I will remind folks, if you've got them, that Q&A tool has been very active here this afternoon, this morning. So keep filing them in there. In the meantime, I'm going to take this opportunity to save the chat myself so that I can send that along to folks.
And also email Aaron.
Come back to
Sorry, say it again, Amber.
Email Aaron. If he doesn't know the answer, he knows who to find the answer.
Yeah, Todd, if you want to just send out.
Go ahead, Aaron.
If you want to just send my email address out to all the attendees, I'm happy if you can do that.
I put it in the chat, and I will save it in the chat and send it again a second time when I follow up with everyone. Thank you. Gabe, did you have
a question? David had asked a very detailed question about Einstein's glial cells and any effect on the knowledge about GDNF. I don't know.
Oh.
You guys have any thoughts about that?
I'm just kidding. Well, GDNF is mostly made by glial cells. And this is actually why it's a problem in multiple system atrophy, because it's the glial cells that get really sick in that condition. So I can probably talk about it that far, but we know that glial cells are really important for that. How it varies for Einstein, I have no idea. But maybe he had a little more GDNF or something. I don't know.
That brain isn't in a jar somewhere in a laboratory?
It's everywhere. Actually, I was at the Mutter Museum in Philly not that long ago, and they actually have a little piece of Einstein's brain there. So yeah, maybe they could start looking.
John is active on the questions and answers. Is it hard to be patient when you're progressing?
Oh,
it is hard.
I think he's commenting back about being patient, waiting for this treatment to be done.
Sorry, John. Yes, it is hard, right?
Just on a
part of the
note,
clinical trial process. It's
right.
The protections are there so people don't get hurt.
Thank you. It absolutely is true. I mean, I've had a family friend who I've watched. He's kind of been standing on the sidelines, and now he's kind of regretting not doing it sooner. But it's hard to watch. I mean, I got to tell you, it's why I think both Disha and I are here. It's one thing to constantly just move levodopa around, but to feel like you're actually trying to make a difference for the disease itself, that is a big part of why I'm here, and I'm sure Disha shares the same.
Yeah.
There's an interesting question. Can you quantify how much GDNF is going in versus how much the brain produces on its own?
We have there's ways for us to start to get at that answer, but the only way is if I were to actually measure pieces of brain tissue. And so we can only do that then in animals, right? And so we do have a sense. So it is supra physiologic, meaning it's way more than what the brain would be producing on its own. But we think that is necessary in order to overcome, the Parkinson's, the underlying causes of Parkinson's. And then I also believe that there's just only so much GDNF that the brain can respond to. And we've sort of just maxed out with what we can do with the GDNF.
Yeah. John's persisting and wants to know what can be done to get the FDA to move faster. So actually there are forums that are being set up, there are ways for patients to speak directly to the FDA. Through the Critical Path Institute actually is another, way to really speak directly. The Fox Foundation does a really good job with, a lot of advocacy this way. So there are ways to get involved. Just know that, many of us are pushing too.
because it's a lot of the way rules have been set up don't really make sense or work for something like cell and gene therapy.
And Aaron, would that be something in your wheelhouse, that kind of advocacy that folks could tap you for? Yes.
Yeah, absolutely.
Okay, good. Okay, folks wanting to knock on the FDA's door and advocate for faster processing, Aaron's your guy.
I would also
Keep me posted, Aaron.
suggest,
So is that my fifth job
you know,
now?
6.
What's
a
that,
lot of
Gabriel?
this is guided by Congress as well. So lobbying your representatives makes a big difference, because they're the ones that ultimately decide on what the budget should be to support these types of studies and give the FDA enough personnel to be able to make these sorts of decisions more quickly. So, you know, that's the other way to do it. Lobbying really makes a difference.
Yes. I think we're actually in a moment where there's momentum, you know, with the Cure Brain the Act, and then Cure Parkinson's Act, and then Michael J. Fox, I think, just got the Medal of Honor this week or something. I mean, these are just the ways that Parkinson's is staying front of mind. It's the top of the news. So, and you know, I also work with patient advocacy. We just got to keep it front of mind. You know, sometimes it just feels like it's so darn close that, you know, we just got to get out of our own way sometimes.
Right, and next month we'll be talking with Bas Bloom about why it's a pandemic, and I'm sure he's advocacy.
That's a great one.
That'll be a good conversation to participate in for sure.
Yeah. All right, ladies. Well, we have more or less run out of questions, but I wanted to thank you very, very much on behalf of the PediActive board and the community for taking your time out on a Saturday. We know you've got families and personal lives, and yet here you are giving us 90 minutes of your own time. So thank you very much for that. Very interesting content, super interesting science that you've got going there. We all hope for speedy results and positive results. So thank you very much for your time. And Gabriel, thanks for joining us. Aaron, thanks for jumping in as a panelist. If you have any parting words, Amber or Nisha, go for it.
Thank you. We cannot do this. We cannot move the science forward without people participating in studies. So please think about it. And thank you for everyone who has. This is the only way we make a difference for people living with PD.
I'm just going to reiterate what she said. Yeah, thank you so much for participating in clinical trials and even considering them. Just knowing that people like you are out there that would want to hear about what we're trying to do and what we're trying to accomplish makes us very happy.
Good.
Thank you. Perfect. Great questions, by the way. That was wonderful. Yeah. It was fun.
Awesome questions, guys.
All right, terrific. Well, we hope you have a wonderful rest of your Saturday. Yourselves and everyone attending. Thanks to those of you who attended. Again, we will be sending out follow-up communications with some of the information that's in the chat. In fact, before I do another thing, let me save the chat as it stands now. That's done. And that's it. And we hope to see you next month, February 8th, with Bas Bloom, 1 o'clock, also a Saturday. The registration is in the chat, and then it's also featured on our website. So thanks again, everyone. Have a wonderful rest of your weekend. Thanks, Dr. Amber, Dr. Nisha. Take care.
Thank you, everybody. Have a good one.
Bye, everyone.
Bye.
Bye.